Okay, good afternoon, everybody. My name is Carol Rogan, and I'm the Scientific Project Manager for Dementia Research Network Ireland. We're delighted to be collaborating with the National Dementia Office this afternoon on this Post-Diagnostic Support Forum. And thanks to Emer Begley in particular in the National Dementia Office for helping put together this programme. And thanks as well to Fiona Keogh from the Centre for Economic and Social Research on Dementia in NUI Galway, who also provided input to the programme. And I'd also like to thank Engaging Dementia for inviting us to be the wrap-up event for what sounds like was a very successful two-day conference that they ran for the last 2 days. So we're delighted to be the last event today. The aim of this forum is to explore the landscape for post-diagnostic supports in Ireland, and we're going to talk about best practice in this area. And then through a panel discussion, which will kick off at 3 o'clock, we'll look at what are the enablers and barriers to the implementation of post-diagnostic supports. So hopefully there'll be lots of interesting discussion there. You'll see that you have a chat and Q&A button at the bottom of your screen. So we haven't built in time specifically for a question and answer session, but if you do have any comments or questions as the presenters go through, feel free to use the chat and Q&A buttons, and we'll do our best to address some of the questions if they do arise. And we have our panel discussion as well, which some of the questions might come up in that as well. Okay, so what we'll do first is start with a quick poll. So we have Grace there in the background who's going to show us a poll for the attendee type. So hopefully we'll see some results in a minute. So when you logged on, people were asked to just click which category you're in. So it just gives us an idea of who we have in the audience. So we have 78 people signed in so far, so that's great, and you're all very welcome. We're great that there's a good turnout for this forum. Okay, so I'm not seeing any of the results there yet, so we might just leave that for a few minutes. And okay, so it looks like there's no audio connection for Minister Butler. So what we might do is go ahead to our first speaker, who's Dr. Emer Begley from the National Dementia Office, where she's Senior Project Manager. And she's going to take us through an overview of the current post-diagnostic landscape in Ireland. Thanks, Emer.
Thanks so much, Carol, and hello, everyone. I know it's very challenging with technology to do this, so thanks everyone for bearing with us. And just to thank Carol in particular for putting together the forum. We were delighted in the National Dementia Office to be invited to partner with Dementia Research Network Ireland on the forum, and Carol has really carried an awful lot of the work around this, so thanks to Carol. So I've been asked to provide an overview of the dementia post-diagnostic landscape in 10 minutes, so I'll do the best I can, but it's a very changing and changed landscape. But I suppose a good starting point is to say that we're not there yet in terms of providing a holistic round of post-diagnostic support for people with dementia, but we're certainly on the right road, and there's been a lot of changes over the last number of years. In terms of the policy position, a starting point for us in the National Dementia Office is the National Dementia Strategy. And within the strategy, under the priority action area, timely diagnosis and intervention, there's a commitment that the HSE will develop a national and local dementia care pathway. So to describe and outline the optimal journey from the point that the person has concerns to diagnosis and then into intervention. And under that kind of overall objective, there's two key elements. One is that following a diagnosis, people with dementia and their carers know where to go for help, and that there is a range of flexible community-based supports that are available to them. So for us in the National Dementia Office, it's a really good starting point in terms of thinking about and developing those critical care pathways for people. And I joined the office in 2017, and while the office was established in 2015, it only became fully staffed in 2017 when three of us joined. And one of the first things we did in conjunction with the Alzheimer's Society of Ireland was to map dementia-specific services in the community. There's a real, deficit in terms of evidence at that time around dementia services, where they were located and what they were doing. So the mapping project was a really good baseline for us. And what it showed wasn't anything, I suppose, anecdotally we didn't know, but it gave us the hard evidence around it. And it showed that there were significant gaps in service provision and inconsistency in the availability of service at both the county and CHO level. There was low levels of intervention for people in the earlier stages of dementia, and there was a focus more on things like daycare in the community. And daycare was the main service offered to people in the community, and carer supports followed. There was low levels of dementia inclusive activities as well, where there were centres of activities, but large areas where there was nothing. And the community and voluntary sector were the main provider in this space, and ASI were the main provider, underpinned by HSE funding in lots of cases, but there was also a fundraising element to that. So that kind of gave us a good picture of where we were at nationally, and really it supported that the commonly held opinion that there was a geographical lottery in terms of access to post-diagnostic supports. And on the back of this, then in the NDO, we developed two projects. One was the diagnostic project, and the other was the post-diagnostic project. And I led out on the second one, and really it was looking at, well, what additional evidence do we need to support the development of care pathways, and to identify best practice to inform those pathways. And those projects ran from 2017 to 2019, and this year we're in the process of developing a dementia model of care. And the model of care follows on from those two initial projects, and it's looking specifically at diagnosis, disclosure, and post-diagnostic support pathways. And we're undertaking the development of the model in conjunction with the DSIDC and with the CESRD in Galway, and we have a clinical expert as well. And really importantly, we have an advisory group who's supporting the development of the model, and that should be published in 2021. And Fiona Keogh later on this afternoon is going to talk to you a little bit about what's in the post-diagnostic part of the model, or where the thinking is and how that's evolving. So the evidence base then that's informing the model of care, a lot of it came out of the work of the diagnostic and post-diagnostic projects. But I have to say as well that there's a huge amount happening both nationally and internationally, and a huge amount of evidence that we're drawing on. But I just want to draw your attention to key publications from the National Dementia Office. Alongside the mapping project, we also reviewed memory clinics across the country, and we did that with the DSIDC, and that showed us that there was, again, inconsistency of memory assessment services across the country. For instance, the Western Seaboard had no specialist memory service, and getting a diagnosis, I suppose, is the first step to getting those critical post-diagnostic supports. So that was a really important piece of work. We also surveyed clinicians to find out where people get a diagnosis, and we looked at, we commissioned a study looking at young onset dementia, those under 65s, to see what their pathways were around diagnosis and post-diagnostic support. And we commissioned two literature reviews, one on diagnostic services and one on post-diagnostic supports, to kind of look at what is the available best evidence to inform the pathways. And alongside this, we were also looking at the effectiveness of existing services and supports. The National Dementia Strategy had a commitment to evaluate the Dementia Advisor Service, and that was undertaken in 2019. We've also looked at evaluating Understand Together in communities, the framework that underpins that campaign. The memory technology resource rooms were evaluated, and really importantly, the dementia intensive home care packages. That evaluation gave us a huge amount of information about what personalised supports should look like and can look like for people with dementia. Many of these evaluations were also process evaluations, which really supports our thinking about how to roll things out beyond where the pilots or the testing concept sites were based. So alongside that evidence, then we do have a changing landscape for dementia services in Ireland. And in the recent budget announcement that Minister Butler made, she announced an increase in the number of dementia advisors. So I've borrowed the little map at the top of your screen from the Alzheimer's Society, and it shows that there are parts of the country in blue that don't currently have a dementia advisor. By the end of the year, we're going to have national coverage for a DA service. And I know Samantha Taylor from the ASI is going to speak later on during the forum, so I won't go into the dementia advisor service in any detail, but that service is going to be further enhanced again in 2021. The memory technology resource rooms are another key part of, I suppose, the service infrastructure that can support the delivery of post-diagnostic support. And when we did the mapping project in 2017, there were 4 memory technology resource rooms. Now there's 27, and there's 1 in every county in the country. Now, some staff had to be redeployed for COVID, but there is a national helpline that people can call to access the MTR service. And each of the MTRs has an occupational therapist who's connected to it, undertakes an OT assessment with the person, gives advice and support on assistive tech, but also really importantly can signpost them to other services and can refer them on. So that is, I suppose, in a developing service. It was the network was formally launched in 2018, so it's still very new. Alongside that, then we also have the Irish Dementia Cafe Network. There's 21 dementia cafes across the country, and we commissioned Engaging Dementia to develop the network. And I know Sinead Grennan's going to speak to that later on as well, so I won't go into much detail about that. But dementia cafes are really critical in terms of information provision, but also very importantly, peer support for people with dementia as well. And I suppose there's lots of programs and interventions, psychosocial programs, psychoeducation programs, cognitive therapies that are being delivered in different sites across the country. And what really struck me during the Engaging Dementia conference was the amount of these programs and interventions that are no longer pilots or testing concept, but are really integrated into existing service and are seen as crucial in terms of supporting people with dementia. And that's a relatively new thing. We also have a national health reform agenda, and Sláinte Care, we're going to see a change in how services are delivered with the move into the community. And we have a very vibrant community and voluntary sector who are providing a lot of those community-based post-diagnostic supports. And underpinning a lot of this, and it's a real enabler, is the Understand Together in Communities campaign. And that's raising awareness of dementia, and increasing understandings of it. And in recent years, we've seen a move into Understand Together in Communities. And Fiona Foley's the national coordinator there, and she kindly lent me some of her slides. But this campaign is really about creating dementia-inclusive communities where people feel respected, supported, and connected. Fiona's working with over 40 national partner organisations who are trying to make their services and organisations more dementia-inclusive. And there's 340 community champions working across the country. Again, many of those are working within health and social care, but see the need to have community responses or inclusive communities that can enhance their work, but also support the person to live well at home. There's a range of resources available as well, just to flag those. There's understandtogether.ie, it's a public-facing website, one-stop shop around dementia, and there's a service finder there where you can look to get information on the dementia-specific services by county and those that are based in your community. And Dementia Pathways is a website for health and social care professionals that has a range of resources for to support practice. There's also dementia training and education programs as well. So that is a very quick whistle-stop tour of the current landscape around dementia post-diagnostic supports in Ireland. I think it's really important to say that it is a changing and changed landscape from a number of years ago, but we're certainly not there yet. And I think collaborative and collective working is kind of a key step to how we can get there. And I'm going to be back for the discussion later if anybody has any questions, but I'll hand you back to Carol now. Thanks very much.
Thanks very much, Emer. That was a really interesting overview there of the post-diagnostic support landscape in Ireland. So we now have our technical glitch sorted out, and apologies for that. So I'll now hand you over to Minister Mary Butler, Minister of State at the Department of Health with responsibility for mental health and older people.
Thank you very much, Carol. And firstly, can I apologise for being a few minutes late? The gremlins got into one computer, so we had to set up another device. So delighted to be here today. Good afternoon, everyone, and thank you for inviting me to join you. I am sorry that we cannot meet in person, but at least modern technology allows us to meet remotely. I would like to commend the National Dementia Office and the Dementia Research Network Ireland for organising today's forum. I believe it promises to be an interesting afternoon to discuss on what our post-diagnostic services look like today and what they should aim to achieve in the future. As you may know, I am passionate about supporting people with dementia and their families. I was co-chair of the all-party Oireachtas Committee on Dementia in the last Dáil with Senator Colette Kelleher. And I suppose we had a really good committee where we left the politics at the door. We came in, we sat down and we knocked heads together. So we worked to ensure dementia was well placed in the political consciousness and highlighted the needs of people with dementia with colleagues in the Oireachtas. And, you know, I am delighted to say I did play a key role in making sure in the programme for government that dementia was front and centre. One of my first jobs as Minister of State with responsibility for older people was to secure a comprehensive package of supports for older people, including the area of budget, the area of dementia in budget 2021. As you all know, look, we have 64,000 people living in Ireland with dementia, and this figure is expected to increase to 150,000 by 2045. So we have a duty to ensure that post-diagnostic supports are in place at an early stage so that people with dementia can continue living well in their communities. And it's so important for the 11 people every day that are diagnosed with dementia that we are able to offer the supports they need, the correct wraparound supports. I suppose it's the whole premise of Sláinte Care, it's the whole premise of supporting people to live well in their communities. And that's why, you know, post-diagnostic supports are hugely, hugely important. There is growing evidence about the value of early intervention for the well-being of people with dementia and their relatives and their carers. Early intervention can help enhance dementia symptom management and prevent behavioural change. Post-diagnostic support can lead to enhanced social contact, helping to reduce isolation for people with dementia and family carers. It can also allow people to come to terms with the diagnosis, which is hugely important for many, many families, understanding the diagnosis and learning to live with it. As Minister of State, I know that there's still much work to be done to enhance services and supports for people living with dementia and those who care for them. More than ever, we need to support these people, as I've said, living at home. The ongoing COVID-19 pandemic has hampered the provision of community supports across the country. And I suppose from my own point of view, I've been inundated with groups that, you know, organisations that run daycare centres, active retirement groups, the dementia cafes. I just mentioned the data one there because I'm very familiar with it. And I suppose this has been a hugely, hugely challenging time for people. But the HSE and voluntary service providers have continued to work to ensure some continuity of service. The HSE has adapted its community services in order to provide a flexible response so that the needs of people with dementia continue to be met during the COVID-19 crisis. Primary care team support is operating nationwide, with referrals being made to community supports, including the Dementia Advisor Service and the local authority community response forums. The fact that we are now living with COVID-19 creates new challenges in ensuring that there is access to the right services and supports to assist people to live well in their communities, but it also creates opportunities to provide services in new ways. Budget 2021 brought a renewed focus on the need of people living with dementia, with some 12.9 million funding for new measures next year. This is a significant achievement in providing for the development of a range of services and supports for people with dementia and their families. The additional funding will support the recruitment of a further 11 dementia advisors in 2021, which will provide a locally based and individualised information, signposting, emotional support service in every county. And I heard Emer refer earlier to the mapping exercise that was done in 2017. And it was one thing that really struck me about the postcode lottery of supports that were available throughout the country. And this is one area that I'm really, really strong on. I believe everybody should be able to access the support they need in their own community. These additional posts, including a national coordinator, will increase the dementia advisor team to 30 by the end of 2021. And I think it's important to remember that when we were going into last year's budget, we only had 8 dementia advisors in the country, and we finally made the breakthrough of getting another 8. So to be able to say that by the end of 2021, we will have 30 plus a coordinator should make a huge difference to people, and there will be greater equity of access for people who need this service. As part of the programme for government's commitment to increase home supports, Budget 2021 provides for a minimum of 250,000 additional home support hours to be allocated to people with dementia, ensuring that more people with dementia can continue to live at home with the appropriate supports. The provision of the €12.9 million for new measures next year also includes €5 million in funding to significantly expand community-based dementia supports across the country, in line with the National Dementia Strategy and the recommendations of the 2018 mapping exercise conducted by the HSE and the Alzheimer's Society of Ireland. I am particularly pleased that the additional funding in Budget 2021 will enable us to improve access around the country. As we all know, a timely diagnosis of dementia is an important step in receiving the tailored support and treatment that enables people to live full lives and remain engaged with their families and communities for as long as possible. Early diagnosis gives the best opportunity to plan for the future. The additional funding will help the HSE to establish a specialist memory clinic in Cork and 4 regional memory assessment and support service in Mayo and Sligo, and then in Wexford and Waterford in the southeast. We also plan to improve the National Network of Memory Technology resource rooms, which will link into the new diagnostic service. The additional funding will also increase access to in-home daycare, which will benefit those who cannot access daycare outside the home due to COVID-19 and the public health restrictions. This is consistent with the vision of Sláintecare to ensure people receive the right support in the right place and at the right time. We are committed to building on the success of Dementia Understand Together campaign and have secured funding to grow this important social movement in 2021 and the coming years. And as I said last week when I met the team from the National Dementia Office, I think it has been one of the most successful campaigns that were ever run. Understanding Together, I believe it brings dementia into the home. When you're sitting down and you're watching television and you see that particular ad, you can relate to somebody in your community, and I think it has done a fantastic job for reducing the stigma associated with dementia. Conscious of the need to improve care pathways and the experience and outcomes of people with dementia in acute care settings, funding secured in the budget will enable us to help to deliver an acute hospital dementia and delirium care pathway and provide the training needs to ensure the effective implementation of the National Clinical Guideline on the appropriate use of psychotropic medication in people with dementia, launched in December 2019. These measures are wide-ranging, they're ambitious, but they will offer a greater level of support to our family members, our neighbours and friends with dementia, their families and their carers. The government is committed to building on this progress and moving forward with the implementation of the National Dementia Strategy. As a long-time advocate for people with dementia, I will ensure that dementia remains a key focus for government in the coming years. Finally, I would like to acknowledge the hard work of the National Dementia Office, its partners, and the many other stakeholders who work tirelessly to improve services and supports for people with dementia and their families. Gorv Mahagut.
Thank you very much, Mr. Butler, for taking time out of your very busy schedule. So I really appreciate you talking to us today. Thank you.
More than welcome.
So what we might do next is show the poll for the attendees that we have today. So if you have that handy, Grace, before we go to our next speaker. So there we have an interesting mix of people, obviously very strong on health and social care professionals, but a nice mix of other people as well. Okay, that's great. Thanks for doing that. So I'll hand you over now to our next speaker, Professor Siobhan Riley, who's Director of the Centre for Applied Dementia Studies in the University of Bradford in the UK. And Siobhan's going to be talking about what does the evidence tell us in relation to what matters most to people living with dementia.
All right, thank you for the introduction, Carol. I'm just going to swap my screens around because I've got 2 screens here. Okay, so I'm delighted to get the opportunity to present our core outcome set for use when evaluating non-pharmacological health and social care interventions for people living with dementia at home. So I led this study from my previous position at Lancaster University. The study was funded by the ESRC and the NIHR as part of the Neighbourhoods and Dementia Study, which was a research programme which was led by Professor John Keady from the University of Manchester. So thanks to all the research team from the universities of Lancaster, Manchester and Liverpool who've contributed to this study, and a big thanks to the lead researcher, Andy Harding. So in this presentation, I'm going to cover three main aspects: the importance of outcomes when measuring effectiveness of services, and I'll tell you about our recent research exploring outcomes that matter to people living with dementia, and then I'll talk through some implications for assessing the effectiveness of post-diagnostic support. So there's growing evidence in demonstrating effectiveness of our care and services, including post-diagnostic support. However, measuring effectiveness is fraught with challenges, not least because people living with dementia have not had a voice in this process. There have been some consensus exercises conducted in this area already. However, the involvement of people living with dementia has tended to be either non-existent or tokenistic. And there's also been a lot of inconsistency in the outcome measurement instruments that researchers use, making it difficult to compare across studies. So there's a strong argument for researchers to agree on a minimum use of outcome measures and avoid inconsistency in the choice of measures. So one of the solutions is to undertake the development of a core outcome set, and the aim of these are to attain consensus from key stakeholders on what are the most important outcomes. And the output is a recommendation of the minimum set of outcomes that should be measured and how to measure them across all trials within the scope of the core outcome set. So this is what we set out to do 5 or 6 years ago. And in our core outcome set study, we started right at the beginning and shelved all existing assumptions about outcomes and how to measure them. We had two main research questions in relation to non-pharmacological community-based interventions for people living with dementia at home. The first one was, which outcomes should be measured from the perspective of people living with dementia, care partners, health and social care professionals, policymakers, commissioners, and research leaders. And the second one was, how should these outcomes be measured? So I'm not going to go into a huge amount of detail about the research methods, but suffice to say that we used a three-phase mixed method study design, conducting 35 interviews and 4 focus groups with 55 people, and we conducted a literature review in phase 1. We identified 170 possible outcomes in phase 1, and then we had to go through a process of whittling this down into a manageable number, and then getting these outcomes into a suitable format so people could answer questions on them in our phase 2. Which consisted of a Delphi survey and a consensus meeting. And then in phase 3, we conducted a systematic review to identify how the outcomes identified should be measured. We made sure we had co-research involvement embedded throughout the study. For example, we had people living with dementia who are part of our advisory group, and they helped design an accessible Delphi survey and provided feedback and input on existing outcome measurement instruments in phase 3. When we've presented this previously at conferences and events, we've co-presented with Pam, a person living with dementia, and Rita, a carer, who were both involved as co-researchers in the study. So in phase 1 and 2, we included 62 instances of people living with dementia being involved. 17 were participants in phase 1 and 18 were consulted as co-researchers when designing the accessible Delphi process. And 21 participated in the Delphi survey and 6 in the consensus meeting. I need to note that the majority of our data for phase 1 was collected in England. So for phase 2, the 54 outcomes that we extracted from the literature and identified through the qualitative research with key stakeholders made up the Delphi survey, and this was sent to over 300 people from key stakeholder groups mentioned earlier. And then again, about a month or two later, this Delphi survey was sent again, and in this, people had to rate the importance of each item. So then we held a consensus workshop, and you can see pictures here of that, to attain our agreement on the core outcomes. And our final set had 13 core outcomes. So we enlisted the support of Tony Husband, the renowned cartoonist, and he's the gentleman on the bottom photograph at the back row. And he attended the consensus meeting and very unobtrusively sat alongside the discussions, capturing these in his cartoons. These had the dual purpose of being a very visual record at the time of the event, but also adding some fun and humour, and we hoped that the cartoons would be useful in engaging the public to our work. So here are the 13 core outcome items which matter most to people living with dementia. So many of these 13 outcome items, which hopefully you can see clearly on the screen, have a substantive overlap with the emergent concept of social health, which is a shift in focus from the symptoms, deficit and disability towards the capacity and potential of the person with dementia. So some of these outcomes we didn't find represented in the trials that we looked at in the literature review. For example, feeling safe and secure, and the importance of relationships, and feeling valued and respected by others, and having a laugh. So we published all our work in open access journals, and I'll show a publication list at the end. And in the longer term, we hope that the use of the final core outcome set will reduce inconsistency in reporting outcome data. Trialists, researchers and commissioners will then be able to compare effectiveness across non-pharmacological community-based health and social care interventions for people living at home. So in the final phase of our research, we conducted a systematic literature review, and we identified outcome measurement instruments that had previously been used in dementia care research. And we wanted to determine how, or even if, the 13 outcome items can be measured. I'm not going to go into all the detail here, but suffice to say that after a lot of work, we were not impressed on the measurement instruments being able to measure all of the 13 items. So it was interesting to learn that the researchers in the evaluation of HSE's National Dementia Post-Diagnostic Support grant scheme decided not to use the standardised measures measuring cognitive function and quality of life or behaviour. Instead, they developed a short evaluation form for completion at the end of the intervention, and the form focused on well-being and emerging outcomes, and there's certainly some overlap with our 13 items. So how is this relevant for post-diagnostic support? So it'll be obvious to most of you that many people with dementia find it difficult coming to terms with the diagnosis. And what should underpin post-diagnostic support, post-diagnostic services, is a person-centred approach and continuous quality assurance, evidence gathering and a commitment to exploring and acting on a person's experience of service, and a commitment to co-designing solutions to challenges identified. And if you're in the position of delivering an intervention, you might notice the qualitative differences in people who receive or attend the interventions and how they feel afterwards. And it's important to have some ongoing evaluation in the form of service user feedback, which could be along the lines of checking how services affect the 13 domains important to people. I'm going to highlight a few of the 13 outcome items as examples of how they fit with post-diagnostic support, and I'll use the cartoons by Tony Husband. So continuing good relationships was rated as one of the most important items. Having a diagnosis of dementia means that decisions about who to tell, when, and how are likely to be made. And it's important that friends and family understand the changes. It's clearly a family affair. So the education element of many of the post-diagnostic support interventions is hugely important in supporting those relationships. So being able to have, being able to communicate with others and feeling connected with others is highly valued in everyday lives. People living with dementia often feel alone and isolated. They may have lost old friends, but when they are able to join a group such as a dementia cafe or a cognitive stimulation group, they benefit from the chatter, sharing of experience and enjoyment, and they manage to get their voices heard in a safe environment. Indeed, the opportunity for social action and interaction and the chance to talk and being able to have a laugh with other people is often a benefit from these groups, not necessarily the aim, but a good outcome from getting the atmosphere right. So being able to do the things you enjoy and want to keep doing. So the sense of loss that people may feel after getting a diagnosis means that people need support to be able to do the things they enjoy and want to keep doing. In the Journeying Through Dementia research study led by Professor Gail Mountain, is a 12-week programme supporting people in the early stages of dementia to continue living healthy, fulfilling lives. The Journeying Through Dementia programme involved people attending the programme. They could attend with their supporter, usually a family member or friend, or if they liked, they didn't have to. The links provided on this slide, which I'm sure will be shared afterwards, will take you to some lovely films about the intervention. So we have used in our I'm Me cartoon on a number of study materials, infographics and postcards. So if you're interested in these, do get in touch with me if you think you can use them. So the cartoon was one of the many cartoons drawn by Tony Husband during the consensus meeting, and it was selected by our co-researchers as the cartoon that most fully captured the essence of the final core outcome set. So we believe that focusing on these 13 core outcome areas and measuring them consistently will increase the quality of evidence and be responsive to what people living with dementia value. As I noted earlier, most of our data was collected in England, so it may not map exactly onto the situation in Ireland. Maybe a similar process could be used to identify and find ways to measure outcomes of greatest importance to people living in dementia in Ireland. As a researcher, I want to ensure that interventions, including post-diagnostic support, are evaluated robustly and rigorously so that policymakers, those making decisions about services to fund or how they should be configured, have the best evidence to make those decisions. And in these evaluations, it's important that we ensure that people living with dementia have their voices heard. What matters most to them is really what ought to be measured. And then we can truly influence policymakers and ultimately influence what gets provided for people living with dementia and those who support them. So just some acknowledgements. Firstly, these are the references to the study which you can access through the links. And thank you to our co-researchers, thanks to all the study team. And finally, I thought you might be interested to know that the University of Bradford has a postgraduate certificate for practitioners with a special interest in dementia. And given the focus on post-diagnostic support as it's being a central part of the dementia care pathway, it's good to highlight. So thank you so much for listening, and please do get in touch if you want to know more.
Okay, thanks very much, Siobhan, for a very interesting talk there, and certainly it'd be interesting to see that research replicated in Ireland. So I'll hand you over now to our next speaker, who's Dr. Fiona Keogh, Senior Research Social Research on Dementia in NUI Galway. And Fiona's going to talk about what should a post-diagnostic support pathway look like.
Thanks very much, Carol, and I'm delighted that the Policy and Practice Forum has come to fruition. It's a great lineup, and I'm delighted to be part of it. I'm just going to share my screen so that people can see the slides. Yeah, okay. So I'm going to follow on really from some of the work and describe in a bit more detail some of the work that Emer Begley was describing earlier. But I'm also really reassured to see the fit, and I hope you'll see it as it comes up with the work that Siobhan has been doing in Bradford. I think there's a very good fit between the areas that people with dementia have identified as being important to them in terms of outcomes and the way we're structuring the post-diagnostic support pathway. So this work is commissioned and led by the National Dementia Office, as Emer has outlined, and I want to acknowledge the project team that I'm working alongside. We're each working on different sections of the overall dementia model of care, the advisory group, which is providing us with very helpful guidance, and also the wider post-diagnostic support group and the consultation group that were put together as part of the work. There is a kind of a health warning attached to this work. As Emer said, the model of care is still very much under development, so we're still actively drafting this and actively working on it. So what you see today is that it is a draft, and it may change slightly, the content may change, but I think the overall thinking is what I want to share with you today. So one of the very important elements of the overall model of care are the supporting principles, and I think Siobhan referenced the importance of the way in which post-diagnostic supports are delivered, and that they should be very person-centered. And you can see throughout these principles that emphasis on citizenship, that people with dementia have the same access to what they need as other citizens, that they're involved in decision making, that there is very much a person-centered approach, and so as well as treating people and valuing people with dignity and respect, people are actually actively involved in their own decisions, and that the dementia care that they experience is coordinated and integrated, and they experience it as being integrated. That it's outcome focused, it's delivering the outcomes desired outcomes for the person. And I think the work that Siobhan and her team have done there will be very helpful in that regard. And that it's timely, that people get the right support in the right place at the right time. And these principles, you can often see them at the beginning of a document and they often just stay there and we kind of skip the page. What we're doing with these is actually building them into the description of the delivery of post-diagnostic support. So we really want these to inform the delivery of post-diagnostic support and care. And through different methods, reviewing evidence, and also from, again, early consultation work that was done with people with dementia and carers as part of the overall programme of work that Emer described. We've pulled that together and identified what we're calling strands, 5 strands of post-diagnostic support. And I think what's really interesting is the way these strands map very well onto some of the outcome areas that Siobhan described. So the strands of post-diagnostic support are understanding and planning, staying connected, staying healthy, supporting cognition, and supporting emotional well-being. And there are obviously a number of supports under these headings. In terms of some examples then under those headings, so under understanding and planning, it's about providing information, peer support groups, signposting, personalised profiles, carer training, advanced care planning, and more. Examples of support to stay connected are things like dementia cafes, community-based activities, assistive technologies, life story work, and so on. under staying healthy, we're looking at interventions around health promotion, meaningful activity, self-management intervention. So Gail's journey through dementia care is very much a kind of a self-management intervention, exercise, telecare, the range of cognitive therapies under supporting cognition, and then a range of approaches to support emotional well-being, such as sensory approaches, creative arts therapies, counselling, behaviour support interventions, and so on. And these cut right across the kind of the care pathway, if you like. And my very, you'll have to forgive my very poor attempt at this. My computer graphics aren't great. What I want to try and convey here is that these 5 strands of support run right the way through from the very early symptoms, from being diagnosed, right through to end of life. So at all stages, while people's needs for these will vary, people will need information, they'll need support around understanding and planning throughout the dementia continuum. They will be supported to stay connected, to stay healthy. Their cognition will be supported, and emotional well-being. So the idea is that different supports will become prominent at different times as people's needs change over time. And the model of care, the dementia model of care, also very much on the pathway, very much includes people with young onset dementia and people with intellectual disability and dementia. So all of these strands and the supports underneath those strands are relevant across the trajectory and for all of these different groups of people. In thinking about prescribing or delivering post-diagnostic support, one of the areas that we're focusing on is really trying to be encourage people to be as specific as possible and to think as carefully as possible about what type of support will work best at what point in time. And there are 4 things or dimensions to think about: the target recipients, the modality, the setting, and the level or intensity. And I'm going to describe these very briefly. So in thinking the target, who is it for? So many post-diagnostic supports are designed for more than one target beneficiary. And some are designed just for the person with dementia. So for example, cognitive stimulation therapy is just for the person with dementia. Some are for the carer only. So a carer training program is just for the carer. Some interventions and supports are for the dyad. So an Alzheimer dementia cafe is for supporting the dyad. Things like psychoeducation interventions are often designed for a dyad. And then others are for the wider family group. So maybe staying involved in meaningful activities and forms of psychoeducation and so on. So we need to think carefully rather than jumping into, oh, well, this is the best support, to think, well, who has the need and what is that need at this time? And then we need to think about how best to provide that support. And there are probably, again, sort of 2 dimensions here. One is whether it's a group intervention or a one-to-one intervention. And some, again, are specifically designed as one-to-one interventions. So something like developing a personalized profile is really a one-to-one intervention. And others are group interventions. And some then are adapted. So for example, cognitive rehabilitation therapy is designed as a one-to-one intervention, but has been adapted to run as a group intervention. And of course, there are benefits to having a group, so that the peer support that comes from a group is an added advantage, if you like, of a group intervention. But it really does depend on what the person wants, what their preferences are, as to what's the most appropriate. We also need to think about being able to deliver something online now as a virtual intervention, as opposed to being in person. And again, clarity on that modality really helps to tailor the support to the person's needs. In terms of the setting, where to provide that support, obviously there are a wide variety of settings, from the person or the carer's own home, maybe day centres. Memory technology resource rooms, I think, are becoming an increasingly important resource, and Emer described the availability of those now around the country, or dementia hubs. Residential settings, because obviously people, that whole continuum we're considering in this pathway. Maybe specific health settings, so on a campus, maybe a room in a community hospital. Non-health or social settings are very important, so from men's sheds to family resource centres, maybe a hotel room for a dementia cafe, for example, and others. Again, what's going to suit best for this person and carer and so on at that point in time. And then to think about what level of support. And this is this concept of stepped care. And it moves from, you know, kind of tier 1, where we're talking about self-management, support from family, friends and peers, support from community and voluntary organisations, through to more formal or structured support from community and voluntary organisations, and maybe specific interventions from health and social care professionals, and on then through to more specialised interventions. So again, our thinking is very much that everybody should be accessing tier 1 support at some point, because that is the staying connected, the you know, the supporting emotional well-being, and then the more specialist supports as people's needs change over time. Just to finish then, to give you some sense of what this pathway will look like. So there are, you know, for the, not just the post-diagnostic pathway, but the whole dementia model of care. So it starts with assessment and diagnosis, through disclosure, the development of a support and treatment plan. And then under post-diagnostic support, you know, we're thinking that we will have a core offering. So everybody who is diagnosed will get this core offering of initial post-diagnostic support, and that is information, a named point of contact, and then onward referral as their needs arise to, and you can't see it there with the video bar, but other post-diagnostic supports based on the person's needs and circumstances, coming from that menu of support that I've just described. So that's again a whistle-stop tour of the thinking behind the development of the post-diagnostic pathway and the overall dementia model of care. And again, I'm happy to take questions after. Thank you.
Okay, that's great. Thanks very much, Fiona. So now we're going to move on to the next session of the forum. And so we're going to have 3 brief talks on examples of post-diagnostic support. So one, cognitive stimulation therapy, second one, dementia cafes, and the third one being the Dementia Advisory Service run by the Alzheimer's Society of Ireland. So for the first talk, we're joined by Colin Doody, who's an assistant psychologist and has been co-facilitating CST sessions in St. Brendan's Community Nursing Unit in Ballinasloe. So I'll hand over to you, Colin.
Hi, Carol, can you hear me?
Yep, can hear you.
Perfect,
yep.
Yeah. Thank you very much for the invitation to present today. And my colleague, Sinead Grennan, is also on the line, I understand. The pair of us have ever had a good time preparing this presentation. So we're going to be talking to you today about our adaptation of a cognitive stimulation, or specifically a maintenance cognitive stimulation therapy program with older adults with dementia in Ballinasloe, County Galway, to a kind of a CST inspired one-to-one phone service over the lockdown 1, if you like. So very, very briefly, because I know a short presentation, what is cognitive stimulation therapy? An evidence-based group intervention with people from mild to moderate dementia. CST itself, the base version is short, it's only 7 weeks. So we had run a number of those in Ballinasloe, and the graduates from this program made up our core MCST cohort. So the MCST program we had in Ballinasloe was running for 26 weeks. It stopped about 4 weeks early, just at the start of March. So we were well advanced through the program at that stage. So what did our group look like? So as I said, it ran weekly for an hour in the St. Brendan's CNU Ballinasloe, and we had roughly between 10 to 15 participants every week, so a relatively good turnout. And the group was structured in terms of themes, so each week had a different theme. This could range from reminiscence one week to household tips on another. And this was kind of, we did our best to tailor that to the abilities of our cohort, who were generally, I think Sinead will agree, and the question and answers afterwards were very well able to go. And each module was themed, as I said, money, various different ones. And the participation is encouraged rather than achievement. So we did have a range of abilities, and it was nice to really foster this sense of it wasn't about the right answer, it was about the effort and the enjoyment. So it was a privilege to work on the program from that point of view. So very brief examples, session activities. So top left there be famous people, who are they, rate them on, controversially we had rate them from the most attractive to the least attractive, who was the best singer, who's the worst singer. So that created some really lively debates in the sessions, things into using old money, all feeding into kind of the reminiscence themes. So the benefits of CST and MCST are well established. CST has been shown to be as effective as medication in some circumstances through a Cochrane review. Carers reported that they experienced their loved ones as sharper after the group, and cognitive functioning is improved and maintained, and quality of life improvement, Spector et al. So it's a good research foundation, as well as anecdotal evidence from our own group. The research was there to support it. So this was then into the nitty gritty, the impact specifically on our service. So March 2020, like all programs nationally and internationally, saw a cessation of the programs in March. So we were coming to the end of the program. We were at 22 weeks or so out of the 26. So we decided, we had the resources, myself and Sinead we had a good bit left in our contracts. So we were there anyway. So we felt that it'd be great to offer some sort of continuity of service. So we decided that we'd adapt the principles MCST to a phone-based service. So we identified 3 separate work streams that we need to do. So we designed and developed and adapted a CST framework for phone calls. We delivered the service, and then finally we evaluated the service. And we actually published an article with DRNI, Grennan et al. If people are interested. So the steps in adapting the program to the phone-based intervention. So the calls were structured similarly to the actual group sessions. So we had a theme every week. It might be current affairs, could be reminiscence, could be, again, those household tips. It was different every week. So at the start, we front-loaded the works. We sent out hard copy resources to ease the participants in the transition. So to kind of acclimatize them to what was going to happen and to give them some tangible hard copy materials to work from. So the facilitators, so myself and Sinead, we completed psychological first aid training just so that we would be prepared ourselves to deal with, just in case any sort of those issues arose. So just to have protection for ourselves and also, more importantly, for the client. So the calls vary depending on the client. Some of them were as short as 5 minutes. Some of them could go on as long as half an hour, just depended on the day and what the client felt they were able for or was open to. So nice variety there. And we developed, again, like a specific safety protocols to our supervisor, Dr. Diana Mahoney, senior clinical psychologist. She supervised all of this work, and we reported directly to her, and there was that constant supervision. So tried to follow a best practice model. So the actual delivery itself, so as I said, it's the once a week phone call. We planned out our structures each week, so trying to keep that intervention fidelity so that each person is roughly receiving the same standard of intervention. So whilst we didn't script, we did have a kind of a set plan that we'd carry out every week. If appropriate, and in certain circumstances, the next of kin of the client was also we kind of engaged with them, see how was the client doing, was there any extra supports needed. So this, could be as simple as sending out extra word searches or something like that. So it was nice to have that contact. And there was, we were very pleased to say there was no break in the service delivery. So the calls were made in the first week that the first face-to-face MCST couldn't take place, and ended in early September. So then evaluating the science, the service, the client experience, just conscious at the time, so quickly go through these. So universally, it was rated really, really highly by the clients. So we did our own internal service review just to see kind of halfway through the sessions, or the weeks, or between March and September. So we just had a quick our own service evaluation to see, was there anything we can improve on. And the feedback from the clients was very, very good. Very, very good feedback from the carers and the next of kin, who felt, one, yes, we were supporting their family member, but also that they had a kind of an access or direct link with the MDT team. So that was very positive, and all clients expressed a wish that the phone calls would continue indefinitely. So our own reflections then, so what facilitated the effectiveness of this program, I suppose, was that we had the pre-existing relationship between the facilitators and the clients. So we had this rapport built up. We felt that it'd be quite difficult if you got a brand new client group and tried to run a CST program over the phone, that would be quite difficult. And even just the relationships with carers as well, that, you know, we had built up a relationship with carers. So there was that external support network that if we were dealing with a client or we needed something to be sent out, that we could pick up the phone. We had that good contact. And as well, the clients had they were very familiar with the session layout. They knew that first of all, we'd be doing a kind of current affairs. We'd be moving to the theme of the day. So the clients they were very well up in the program. They knew they knew the score. So evaluating the service, the challenges. So 4 key challenges that we came across. So there was the fact it was on the phone, is there was a reliance on a single sensory input. So when you're in the sessions when we were in person, you know, there's sight, sound, touch, taste, smell. With the phone call, it was just sound. So that created its own problems, specifically if somebody had a hearing impairment that was really exacerbated. Again, we didn't have the same amount of resources over the phone. We relied on stuff that we could send out periodically. We couldn't produce stuff in session. And the fact again that it was over the phone, and there wasn't like there was no group dynamics, unfortunately, over the phone. So again, it was more limited. So very quickly then, the MDT perspective, the MDT team rated the intervention very, very highly, and they felt that it provided a good social outlet for our clients, and they felt that overall referrals for anxiety specifically were a lot less than they had predicted while the service was being running. So very positive outcome from that. And finally, to wrap up there now, so overall, from our point of view, we felt that it was quite successful. Our clients reported that they were they found a very positive, overwhelmingly positive valuation by clients and the MDT team. And it was nice, the clients commented on the sense of togetherness they felt with the MCST group, because they were cocooning. They didn't see us, they didn't see any of the rest of the group, but they still felt that togetherness, which I think is really important. And it raises some interesting prospects for CST and MCST. That if you have clients maybe through illness during the normal course of a program, you know, might miss sessions through illness or bereavements, perhaps, that you could adapt missed sessions to a phone call for, you know, to provide that continuity if people are missing a couple of weeks at a time. So thank you very much for your time and attention. So again, this is the reference for the short publication we have on this adaptation. And thank you very much for inviting me to present today.
So next we'll hand over to Sinead Grennan and Carly Duggan, who will present on the Irish Dementia Cafe Network. Thank you, Sinead and Carly.
Okay, great. Thank you so much, Carol. So I'm going to just talk a little bit about the network, and then I'll hand over to Carly. So I just have a short PowerPoint here. So I'm together with Grace Dennison, the Irish Dementia Cafe Network coordinator. This is a project. There we go. A project that was commissioned by the National Dementia Office in July 2019, and Emer Begley has commented on that earlier on, funded by Pobal Dormant Accounts through the Department of Health. And it was based on the provisional findings of research that was carried out by the Centre for Economic Social Research in Dementia on Dementia. It's now published by Tihan et al., Family Carers Perspective on the Alzheimer Cafe. Apologize for the slide, but these slides are moving on of their own volition. So the findings of that research were that cafes were located sporadically around the country. There were about 26. There was a lack of cohesion, there was variable quality, variable attendance. However, there was clear evidence of benefits for people living with dementia and their carers. And the research also showed proposed some central pillars to the Dementia Cafe. So the project objectives supporting the rollout of a flexible Alzheimer cafe model across Ireland, the establishment of new Alzheimer cafes by engaging with communities of interest, particularly Understand Together, and that's already been commented on earlier on, provide support and guidance to the existing Alzheimer cafes, develop an Alzheimer cafe network, and then raise awareness and understanding of the Alzheimer cafe model. So we had a 3-phase plan. I'm not going to read out all of this, but you can see phase 1 was August to January, really all about engagement with an expert advisory panel, with the cafe coordinators, holding meetings together, really starting to discuss the cafe model. Phase 2 then, there was to be a cafe learning networking day in February, which had to be delayed because of COVID, and then looking at branding, promotion of cafes, and now we're in phase 3. So the cafe has been launched and we're working on a toolkit and how-to workshops. So I'll come to that in a moment. Key project activities, well, we established an expert advisory panel. We engaged regularly with all cafe coordinators. Together, we collaboratively developed a principle-based framework for the Dementia Cafe. And this was really, really good and really interesting. It kind of allows for flexibility. A lot of the cafes, and the Alzheimer Cafe is built on a Dutch model that's really quite strict and rigid. And what the Anya Tehan and Eamon O'Shea found from their research was that cafes around Ireland variously had different types of, they were run in different ways. And really there needed to be flexibility to allow for difference, but also there needed to be principles that would be shared so that there would be more cohesion. Also, we collaboratively developed, discussed what would be the key activities of an Irish Dementia Cafe network. We also decided on a shared name, Dementia Cafe rather than Alzheimer Cafe. So around the country, there were dementia cafes, Alzheimer cafes, memory cafes. The minister commented there on the Deisha Cafe down in Waterford. So there were all different types of cafes, but all sharing similarities and similar principles. We set up a virtual cafe in response to the COVID crisis in March, and then we also mentored other cafes in the virtual cafe, engaged with communities of interest, like I said, raised awareness of the cafe service, launched it in September, and then established a digital presence. So here are the 4 pillars of the Dementia Cafe: atmosphere, information, support, and community. And you can see from the other speakers there how it really is part, in terms of the post-diagnostic pathway, it really is touching a lot of the bases and helping to be a part of joining the dots and reducing fragmentation of services. So it's a welcoming once monthly meeting for people who are affected by dementia. So it's people living with dementia, their families, their friends, healthcare professionals, and then people in the local community who are interested in supporting a dementia inclusive community. So everybody is welcome to attend. Cafes run by local voluntary steering committees, and they are always free of charge. So here are just some images from social media, our virtual dementia cafe. So we set it up weekly, Friday morning, 11 a.m. in April. It was adapted, so it was the Dementia Cafe model, but just adapted a little. So there was still a theme every week, very much focused on, you know, the atmosphere. So bringing the cafe into people's kitchens. So I think there was a phenomenally positive response to it and a real sense of togetherness. And people kind of got it. I mean, social supports, unfortunately, with COVID, had to be suspended, cafes, just like other social supports. But people really did embrace this notion of the cafe coming into their home, even though they couldn't go out to the cafe. The virtual cafe, running it weekly, also gave us an opportunity to mentor other cafe groups. So you can see there over on the left, that is Maeve Montgomery, one of the Alzheimer's Society's dementia advisors, and she is a coordinator of several cafes. So she spoke at our event a few times, and then she is also now running a virtual cafe. Here's a photo from one of our virtual cafes. Yep. So you can see, I will go back to it, like you can see the energy and the joy, and it really does capture that the cafe is all about atmosphere. It's all about togetherness, peer support, learning, supporting each other. We launched the cafe network in September. Minister Mary Butler, thank you very much, Minister, who launched it for us, along with Miriam O'Callaghan, who had launched Ireland's very first Alzheimer Cafe in 2011. And we had set that up as a multi-stakeholder initiative, which involved a lot of the same organizations actually that were then involved in the expert advisory panel for this project. So the DSIDC, the Alzheimer's Society, Experts by Experience. Kevin and Talina Quaid, who are on the expert advisory panel and who also run the Canturk Memory Cafe, they were on the panel. They're running a cafe, and they also spoke at the launch very kindly. You can see Anya Tehan there from the Centre for Economic Social Research and Dementia, who spoke about the project. Emer Begley, I spoke to, and then there's Grace Dennison, the other coordinator. This is our website. We launched a website, dementiacafe.ie. So you can see there a photo kind of capturing what it's about. And here is our cafe finder on the website, find your local member cafe. So here are the member cafes around the country. So you can see Cavan, Monaghan, Louth, Meath. Now, as you'll see them popping up, you will also notice the black spots, and that's the next focus of this phase of our project, really looking at those parts of Ireland where there are no cafes and how we can support them to start up cafes. So the next steps, virtual learning networking day, reaching out to support communities of interest, a cafe toolkit, development of resources, and then we'll be holding those 2 information workshops. So that is the Dementia Cafe. I will now hand over to Carly.
Hi, thanks very much for the invite. Well, I'm one of the people that really hugely benefited from attending the cafe in Donnybrook. When I found it, I literally went and attended it every single month. I was really quite addicted to going because I had so little supports in my own life. I was really, really relieved when I came across the cafe. And when Owen got the diagnosis of dementia, when he was told finally in the second opinion, I brought him along, and it was one of the really safe places for Owen to come to. We didn't have much support outside of that cafe. You know, it was a very, very difficult time for the 2 of us because he was young, you see. Owen was in his 50s, in his mid-50s when he got the diagnosis. And it was a really frightening and a very, very lonely place for him to be. So when we arrived at the cafe, he was completely relaxed. He enjoyed himself. He loved going every month with me. And he engaged with people. And I don't mind admitting it, but we had, I suppose, the rowdiest table in the cafe. We were always making noise. We were always laughing. We had a great crack. And it was one of the few places I found that people didn't ignore Owen. In general in life, people would talk to me, even if Owen was beside me. They might ask me something about Owen, and I would say, well, look, Owen is there, it's fine, you know, talk to him yourself. But in the Alzheimer Cafe in Donnybrook, people looked at Owen, they chatted to him, they talked to him, they called him by his name. So he was never ignored like he was on the outside. And he actually made new friends, because as I said earlier, having Alzheimer's when you're very young, well, I think it's a very lonely place for anybody, but I think when you're a younger man, it's a much lonelier place to be. And this was one place I found that Owen actually developed friends. And, you know, we did develop good friends, and we have found good friends from the Alzheimer Cafe in Donnybrook. And this idea of physically going to a place where there was physically warmth, there was friendship, there was hugs, there was kisses, and then there was the tea, the coffee, just the whole social ambience of the place. And that is actually very, very huge to somebody that is, if you like, more ignored on the outside. And it's in the world of dementia, and when you have dementia, you tend to lose friends or some of your friends on the outside. But in this place, he didn't. He gained friends. And it was just some place where we felt very safe and very secure, and where we were welcomed. And Owen was accepted for what he was, and I was accepted as a carer. So we literally looked forward to this every single month. It was on my calendar. We never missed a month session. We went, we enjoyed it. We were the first to come to the cafe. I think we were probably one of the last to leave as well every evening. And it was just somewhere we could go together collectively, and it was okay to have dementia. It was okay to have had that diagnosis because people in the cafe understood. And the other thing I really liked about it as well is that I found I learned a huge amount from listening to the talks, because there was a talk every month in some aspect of dementia, and I got a huge amount of information and support just by learning where I could go and what I could do in relation to dealing with this. Because for me, you see, it was a huge crisis, not just because Owen was young, but just after we got married, he had a heart attack. So we had a whole plethora of different medical problems over all those years. So by the time I got the diagnosis of dementia for Owen, I was on my knees, and I thought I was demented myself at the time. I was in such a state. It nearly broke the two of us, because it was just like the last straw of many years of a nightmare. But I have to say, for me, on a personal level, pardon me, attending the cafe was for me a lifesaver. On a personal level, it was a complete lifesaver. And it was the really first, I suppose, area of support that the two of us got. Now, I did obviously attend a monthly support group myself for carers, but obviously I couldn't bring on to that. So the cafe to me was a lifesaver. Now, that might actually sound like an exaggeration, but in actual fact, it isn't. I was hanging off a cliff at that point in time, and this was somewhere I could go where I could literally sit down and relax and have a chat. We had a laugh, and Owen was completely himself there. And he would physically help then when the cafe was over at the end of the evening. He would get up, and he's quite a shy man. He's quite introverted in some ways, but he would get up and he'd go around the tables and he'd collect the cups and saucers. He'd bring them over to the sink, and he was helping, and he got a really buzz out of that. And I was delighted and amazed when I used to watch him doing that, because I knew he felt safe. And I mean, we came from an environment and a house where we really weren't safe, and it wasn't really a very secure place where we were living at the time. So this cafe was just a lifesaver. It really was. And I would recommend it to anybody, anywhere in Ireland, if you have or are dealing with any kind of a relationship with dementia. Definitely, it's some type of support that you can look at and engage with. I think you genuinely would benefit from it.
Hey, that's great. Thank you so much, Carly, for sharing your personal experience there. And you can really sense from you the importance that the cafe played in yourself and Owen's lives. So thanks so much for sharing that, and thanks Sinead as well for introducing us to the cafe network. And Carly will be joining us on the panel discussion. I know we're very late on time. Unfortunately, it's just the addition of a few extra minutes on it from everybody's talk. So hopefully everyone's able to stay with us. So we'll crack on. So our final speaker then before the panel discussion is Samantha Taylor, who's head of the Alzheimer's Society of Ireland's Dementia Advisory Service. And Samantha will talk about this service.
Hello everyone, and I'm delighted to be with you today and to be part of this forum. And as Carla said, I've just asked to give an overview of our Dementia Advisory Service, and as other speakers have said, we're in a happy position where we can now make this a real national service, and that's been the result of many years of hard work by a large number of people. I suppose I just wanted to reflect, in 2013 we started with a pilot with 2 people based in Dublin and Cork, 2 of our most experienced staff, and we did that because there was such a consistent expression of need from people with dementia and their families to have that dedicated point of information provision and signposting that was accurate, accessible and timely. And we were very fortunately able to kind of grow that team from 2 to 8. And since 2015, we've had a team of 8 staff working across the country. And as the National Dementia Office came on board, the HSE and the National Dementia Office have helped us and financially supported us to deliver that and indeed work towards expansion of the service. So I suppose at its core, when it began, and we were very fortunate, there was models in the UK and in Scotland particularly of similar services, and we drew heavily on those, and we drew on our experiences coming through from our national helpline and the ASI services, social clubs, cafes, home care, daycare, respite services, to kind of understand what people were looking for. And we built the service around information and advice, and a pathway to support people to access services and supports, and a kind of a crisis prevention. So we knew the earlier we could get to people, the earlier we could provide this service, the more beneficial it was. And what we've, I suppose, come to understand through running the service over these last 7 years is that reducing social isolation and stigma, enabling participation and engagement, maintaining independence and well-being, and really supporting the connection, peer-to-peer support, have been absolute key outcomes and kind of pivotal parts of this role. And I suppose when somebody accesses this service, and it can be a person with dementia or a family carer, we go through, we meet and we go through specific things that we know people need information about. So we will talk to people about, you know, very practical elements like driving, or after a diagnosis is confirmed, or, you know, thinking about starting to plan legal and financially. But actually, relationships and staying active and doing what is important to you and what you feel makes you you are also key parts of that service, of this service. And relationships in terms of not only talking to families and friends about the diagnosis, but also meeting new people. And I think previous speakers have really reflected on that, and I think this service has definitely worked towards enabling that for people with dementia and their families. And it is very much, we work with both, and sometimes the person with dementia, we're working with them completely on their own, and families dip in and out. Sometimes we're working with a family member, and the person with dementia may participate in some meetings and may not in others. So it's a real, depending on who we're with. And we were very focused early on that we would, we wanted to understand what the impact of the service is. And in 2017, we did our own internal client impact survey to try and understand how people were, what difference this service made. And then we were really delighted when the HSE and the National Dementia Office commissioned an external piece of research. Emer mentioned it earlier, led by Alice Coffey, and that really gave us tremendous insights into the service. It not only spoke to people with dementia and their families who were using the service, but it also spoke to health and social care professionals. And it gave us really good insights to what the service meant to them. And again, I suppose the individualized, person-centered part of the service is hugely important, and having that one place to go, that dedicated place to go. But also what has come out is the more community piece. So the, you know, being out and about on our mobile information centre, doing talks in men's sheds and in libraries and active retirement, and people seeing that there was support there, and people understanding that actually they weren't alone, and actually understanding that it was okay to talk about it. And I think our the feedback from the whole health and social care professionals was also really an endorsement of the service. The evaluation in 2018 spoke to health and social care professionals who worked with dementia advisors across the 11 counties, and also those who didn't. And that gave us really good insights around the gap, you know. Again, many of the teams we work with have really reflected very strongly how the DA service, you know, was a really good add-on to what they're doing, and enhanced the service that they provided. And we're working very hard to integrate across a number of diagnostic teams, but also community-based teams, public health nurses, community hubs, social care workers, occupational therapists. We've worked very well with the memory technology libraries as they've grown and developed, and they're a really great addition. So I suppose I did want to also mention that, you know, throughout COVID-19, we have operated. We've had to, like everybody else, adapt and change what we're doing. The team has been extremely busy over this time, and ASI did some research on caring and coping with dementia during COVID-19, and you know, it very much the Dementia Advisor Service fed into that. And I think the team have, you know, had to dig deep at times over the past 8 months, like every other team, And we've worked really hard to make sure that while we're not meeting people in their homes, we are continually to meet them. I suppose we've had a 48% increase in the number of meetings that the team have had, and we've had well over 1,000 new clients, despite the fact that, you know, diagnostic service had to close for a period of time this year. And we've really, you know, our website, we've added on new sections, we've developed new resources, some in partnership with the DSIDC, others, you know, working with other teams to just really try and be there as much as possible. We've done 4 webinars across the country on items like mental health and well-being, carers resilience, but also art appreciation and eating well and nutrition during these times. So lots of impact in terms of, but we've managed to keep the service going throughout, working very closely with our national helpline. And I know people, both Minister Butler and Emer have referenced the expansion of the team, and it's a wonderful situation for us to be in, that our 8, and here's the map that Emer referenced earlier, all those blue counties, you know, we're actively recruiting now to be able to provide turn those counties green and put at least a part-time service in those counties now. And as Minister Butler said earlier, the budget 2021 means that a further 11 posts will allow to us, where we have a part-time service, to make it a full-time service, and where we have counties that have quite high density populations, we'll be able to add. And we're really excited about that, and we're working closely with the National Dementia Office to ensure that these teams are integrated very well and linked with existing supports and services in those counties, so that we can work in a really connected way and work together. And that's it from me. I look forward to the panel discussion.
Okay, that's great. Thank you very much, Samantha. That was a very interesting presentation there. So we're going to start the panel discussion. So we're obviously way over time, and apologies to all our attendees. Hopefully you can stay with us. We'll, if we can, we'll run until 4 to give us the full half hour. So hopefully all our panelists are able to stay with us. I'm just going to introduce you. You've met Sinead, and you've met Carly Duggan, and you've met Samantha Taylor and Emer Begley. So our 2 extra panelists are Professor Sean Kennelly, a consultant geriatrician and clinical director of the Memory and Assessment Service at Tallaght University Hospital, and Susan Scally, principal officer in the Social Care Division at the Department of Health. So thanks for joining us today. And so some of our other speakers are tuning in as well. So if they want to contribute, they can do so. And so Matthew Gibb is going to be the moderator for this session. And Matthew is the director of the DSIDC in St. James's Hospital. So I'll hand over to you, Matthew.
Thanks, Carol, and thank you for putting together this this very, very interesting forum. It's been great hearing what everybody's been up to. So I'm not going to waste any time because we are well behind schedule. So I'm going to plow on with the first question. Now, I thought I might, I'm going to open up these questions to the full panel, but just to get things rolling, I'm going to ask Sean Kennelly there just about, just perhaps in his opinion, if he might tell us what he thinks is an appropriate care pathway for people diagnosed with dementia, and how that's been affected by the outbreak of COVID-19.
Thanks, Matthew, and thanks to all the speakers. It was a great range of talks, and I suppose in particular, thank you, Carly, for sharing your experience. And I was particularly struck by your phrase when you said that you were hanging off a cliff, and the importance of those interventions around supporting you. And it does also highlight that as reassuring and as positive as it is to hear about all the endeavours that we have underway, we are also, and as a service, and myself included in how we do it, there is a failure here to support people when they get to that sense that they have very few places to turn to. And I think that's the essence of what the post-diagnostic systems are, services are, and how important they are, because people are left with that sense. And that's, what you expressed resonated with me, because it's something that's expressed in clinic quite often. So thank you for that. I think with regards to post-diagnostics, it really comes down to, it starts at disclosure, and it starts with, proper disclosure and access to disclosure. Minister Butler mentioned that. And actually, the fact that people should get an appropriate and positive and hopeful disclosure with regards what it is going, is going to happen. Give them a reassurance with regards to the accuracy of the diagnosis. So access to an accurate diagnosis is really important for setting the ball, in motion for then participation in those post-diagnostic pieces. It's very hard to recover. I often use the analogy of, a ship goes in the wrong direction. It's very hard to correct it afterwards if somebody hasn't had an accurate disclosure. And with the best post-diagnostic services possible, if somebody hasn't had a positive and accurate disclosure, that can send things going astray. I think also, it's this for many decades, I think we had these kind of silos of the social care model and the biological or / medical care model. And I think what's been really important over the last decade, and particularly in the last 5 years, is we stepped aside from that. Okay, so I, as a clinician, have a responsibility to start somebody into their post-diagnostic pathway. So it's not enough for me to be doing a memory clinic. I have to be delivering a memory service, and that I have to be part of that ecosystem of support then. So when somebody goes to a cafe and an issue is highlighted or a question is prompted, that I'm able to see them in a seamless fashion again. Or that when somebody, as frequently happens, so we have the dementia advisors sit in our clinic once a month, the 2 dementia advisors from our service, so that there is this connection between these post-diagnostic services and that diagnostic piece. And that is, if you like, that ecosystem of support that we need to kind of get more equitable access to across the country, and kind of break down that separation between this, what was traditionally called biological model versus social care model. It needs to be one model and it needs to be one pathway. And there shouldn't be a detachment across services. And then the other point is also where we diagnose and how we diagnose dementia is changing. So our whole focus is about getting a timely diagnosis at much earlier stages, when part of the post-diagnostic pathway has to be brain health and has to be about how we get people into, and we find that as a really important element of the diagnosis or disclosure around hope, is that you're giving people things that they can do. And our exercise programs, which both the supporter and the person who's living with dementia can participate in, and those kind of things where they can, similar to the cafes, they can participate in them together, and there's kind of a positive focus around them and a sense of, proactivity, and we're doing something and we're working together. And I think that's a really important piece at that early stage. And then I think the next thing is capacity, and making sure we build capacity across the system to deliver, these services, because at the moment, even with the very welcome investment, we're still falling well short of the necessary, case management and support that needs to be there for people with dementia to kind of do this in a holistic fashion, in an integrated fashion. So I think we need to be really scaling up capacity.
Yeah. I just asked Sean, I'm very aware and impressed by the range of services you've managed to leverage through the community there. I'm just wondering, how badly has COVID-19 impacted on your services? Just briefly.
So I think in the first wave, significant impact, because I suppose the disclosure piece and the clinic piece. Now, what we did is we went straight to telephones, and everybody in the service on the database got a phone call. And anybody who identified as that they were struggling, then they got follow-up calls, and they were kind of brought into it. And there would be a close relationship with the nurse practitioners here in the clinic. I think the big impact from COVID has been the diminished access to day centres, which was mentioned. So the lack of access to day centres, lack of access to respite, that has been a massive impact with regards to how we support people living in the community. And as much as I understand the challenges in getting those services, and I would be sympathetic, and I've worked I would see people both in clinic, at home, in their homes, and in nursing homes. So I've seen that range of impact of COVID, so I don't underestimate it. But we have managed to get a lot of other things open, and we have managed to resurrect an awful lot of services, and yet these pieces haven't been, resurrected quite to the same level that that you would hope to get them back up to. But there's no question, I think the day centres and the respite access has been the biggest impact that I certainly would see as a clinician.
Thanks, Sean. Carly, I was just interested from a very personal point of view. Your perspective. I mean, you're obviously. I'm wondering how COVID has impacted on your ongoing care for Owen.
Well, to tell you the truth, Matthew, obviously I can't get into Owen now. I did have a couple of visits to the glass in the early stages, but that's not possible at the minute. And like he's kind of ill at the minute in that he's got an awful boil, but I can't get into him, and I really find that frustrating. So when they do a video call, you know, through the WhatsApp or whatever it is, I do my whistles with him because, you know, he was into birds and all that. And he tries to whistle back. He tries to put his lips together. But I am finding it really, really hard because I would go into him every day, sometimes 2 or 3 times a day at weekends and that. And he was used to having me going in and playing with him and blackguarding with him, all the things that I used to do in the cafe. And now that's all gone. So he doesn't have me going in, you know, messing with him, blackguarding with him, tormenting him, you know, and getting him to do all kinds of mad stuff, you know, like we always did. And I find that awful. So when I see him on the WhatsApp or whatever you call that system they have, I find it awful because I know he can't really see me because his eyes are closed most of the time. You know, he can hear my voice and he knows my daft whistles because I don't ever get it right. He was always telling me that. But I do find it awful, to be absolutely honest with you. And what I want to do is I actually want to break into the nursing home. I know I get arrested and all that, and I don't want the hassle, but I just feel I should be getting in there, even if it's breaking all the rules, and I know I can't. So, because I see him going down, and he's so young, and, you know, it's such a lonely experience for him, and there's nothing I can do, do you know what I mean? And I have that level of frustration.
Yeah, sure.
And I don't know what to do.
It's very, very hard. I feel for you, Carly. Emer, I was just wondering, like, I mean, we've been working on this, you know, the overall model, and I was just wondering, again, just from I mean, you're seeing things from a slightly different perspective. You know, we're very, very much immersed in the kind of the health system, if you like, and I'm just wondering from your perspective, you know, from looking outside the box slightly, what you feel would be the main elements of that care pathway, or the, I mean, I know primarily we're talking about post-diagnostic supports here.
I think one of the things that struck me, and it's something that Carly said as well, and Sean touched on, it's this trying to avoid crisis, you know, where people come and look for a service when they're in crisis. And it's really about more proactive type care. So the person gets on the care pathway early, you know, the diagnosis leads into continuity of care in the care pathway, and it's a seamless transition. And there is some type of there's a single point of contact for that person if an issue emerges, but also that there is a holistic needs assessment for the person and the services wrap around them, where that needs assessment can be updated over time as needs change. At the moment, I think, well, it's changing slightly, but at the moment, people are really hitting crisis before they get any type of intervention. And it's really about trying to avoid that. You know, the aims of the National Dementia Strategy are to support people to live well at home for as long as possible. And we have to have that if that's something that's going to be achieved.
Yeah, yeah. And I think that's something that all practitioners are witnessing, you know. I'm just conscious of time, so I'm going to bump along to the next question. Susan, just to give you fair warning, I'm gonna pop at you first, okay? So just I suppose looking to the future, and hopefully this is a future where you know, kind of COVID-19 is well in the rearview mirror. So how do we achieve these aims? How do we get this care pathway in place? And what again, what would the main elements from the Department of Health's perspective be?
I suppose, I mean, the first thing really is that Sláinte Care really sets out the approach in terms of, you know, getting the right intervention, getting it at the right time and getting it in the right place. And everything that previous speakers have spoken about in terms of access to the care pathway and getting access to the intervention, or whether it's getting access to a timely diagnosis and then getting access to services and supports, and then getting a continuum of care that sort of provides the appropriate supports at different stages of the journey, really, right up to end of life. So in terms of the department's perspective, it is about implementing the National Dementia Strategy, and I think everything in relation to the practices and the policies, it's all there within the strategy. It's a very good strategy, but we have struggled really to resource it. the National Dementia Office have been excellent in terms of piloting, testing concept, getting things underway. And I think this year's budget was the first real time that I saw we actually are getting some substantial investment to actually make some of these important initiatives happen. And I think from the department's point of view, how we care for older people has to change in terms of COVID-19 has taught us some lessons around the risks of having a model of care for older people that's overly focused on residential care. So then you're back again to making sure that the services are delivered and accessible as close to home as possible. And so the range of initiatives that we hope will be supported through Budget 21 funding and into 2022 are all dealing with different aspects of that. So the Dementia Advisor Service, expanding that, because again, what we learned from COVID-19, when the Dementia Advisor Service wasn't sort of doing its normal service, it started to pick up people who it wasn't aware of, and then getting more access to memory assessment services, and getting, apart from St. James's, getting a new service in Cork. So really kind of making the model of care happen, and then trying to ensure that people don't end up having, and the crisis point that Emer made is very important, that often it's in a crisis that people maybe end up prematurely in residential care, and if they've got the services at home, maybe they would have been with support able to remain at home. So it is an integration between, we have a dementia strategy, we have a carer strategy, so supporting the carer and trying to support the person to access services at home, and then the point around then if you can't provide the service, can't provide daycare services in the same way that you give that access at home. But I absolutely agree with Professor Kennelly that really need to get day services back up and running for people with dementia. So I hope that has answered your question somewhat.
Yeah, I think we all welcome the increased commitment in this year's budget. I don't think anybody's going to knock that by any stretch. I think the essence here is about widening the choice that people have right across the spectrum. I think that obviously, I personally agree with you in relation to residential care. I think that's a major issue. Samantha, just to jog along to you now, what do you think would be the primary or the most important parts of a post-diagnostic support pathway?
For me, it's the integration piece that Professor Kennelly mentioned earlier, and where we have managed to do that, and we're very integrated with Sean's team. Actually, it has really borne fruit for everybody. And actually, even during COVID, I think it really came into its own, because not only was Sean's team on the phone, our team was on the phone, and actually we were able to talk to each other, and where people were struggling, we were able to kind of troubleshoot and navigate a new way of doing things, because everybody was trying to figure out a new way of things, because those seeds were there and because that integrated piece was there, and our teams were able to work with his team so well. I think that's the most essential piece, and what it allows for is where the diagnostic is happening and the disclosure is happening, the follow-up then with different services, ours being one of them, but it's only one of them. There has to be that range and that toolkit that then has to be available to people as they go along. And I suppose what I would say for me is, I think we've all had that moment where we've had someone sit in front of us and go, if only somebody had told me this 6 months ago, or a year ago, or worse, 5 years ago. We've all been there. And really what we want to do is make sure people have an awareness of where they can go, and that it's integrated as they go along it, because that's what stops that.
Yeah, I think it's a really good point. It's a great way of the integration piece there you're talking about is with the dementia advisors who sit in once a month with Sean, and the memory assessment service there in Tala, and the kind of transfer information backwards and forwards is a bit, cross referral, which it seems to work quite effectively, doesn't it?
And in fairness, working with the National Dementia Office now and expanding the team, they're really committed to helping us replicate that, across the new areas that we're working in and building it in areas that we're already, because we know it works, and I think it's wonderful that we have been resourced to do that. But it's part of the jigsaw. And there's other services that are needed as well, as you've mentioned. And I suppose, I think post-COVID, there's been a huge amount of innovation actually during this pandemic. People have really stopped and thought, well, how can we do things differently? And I think we can harness that as we go forward and think about how we do it. So as important as daycare is, and we all want to see daycare back open, and we're working very hard to do that, models like the daycare at home model are supporting that process. And there's some learning for us as we evaluate that more and understand that more. Maybe we have hybrids and mix of different things going forward, and we're not over reliant on one thing that could be vulnerable to a certain outbreak of whatever, so I think we're in a good place to build at this point, and the budget 2021 has definitely given us that space, but there's for sure more road to go.
Yeah. So just to dig down a wee bit there, your daycare at home initiative, what does that look like on the ground?
Well, at this point, we've rolled it out. I think we're delivering over 1,000 hours at this point. So what that does is, for people who were accessing our day centres, we're able to provide a 2-hour block of activity. That's we've done an assessment to understand what the person's needs are, and that's led by our day centre nurse manager, that assessment. And then based on that assessment, where a care worker will go to the home for a 2-hour block, and the focus is on activity and engagement and what might be needed for that person, what they want, but also for their family member to have some respite. Because what we've really heard during when everything was, the first wave, if you want, families really are struggling, and they've had a really challenging, and despite all our phone calls and all our best efforts, there was a lot of isolation and loneliness. And I suppose this is, in the absence of a full day centre and in the absence of respite, this is a block of time that allows the person to meet another person and be engaged and stimulated, but also the family member to do something else, which they really need to do. So we're rolling that out, and we've been really supported by the HSE on that, to do that. But we're simultaneously working on what day centres can we get open, how can we get them open, and we're trying to work really hard to deliver that, because we know that's important too.
Yeah. Well, look, I think hats off to yourselves and to the HSE for thinking outside the box and actually delivering services that are effective, immediately in people's homes, which is fantastic. I'm just going to open this up to the panel, so feel free to kind of step in. So what can we, and we're not all practitioners, but just as members of the panel, perhaps, what can we do to increase the implementation and the uptake of these post-diagnostic support programs? From a personal point of view, I've been heavily involved in the Alzheimer Cafe in Donnybrook, and it's been running now for a good number of years, and we over that time we've seen kind of our numbers kind of wiggling around a bit, and sometimes it can be very hard to recruit people, if you like, or to encourage people to attend. And there's such valuable forums. Now, I was just wondering what other people are bound to have difficulties like that in certain areas. I was just wondering, what do we do? What can we do to try and encourage people to take up these and implement these, not only people who are using the services, but also the professionals who are running them? How do we encourage people to take up the cudgel, if you like?
Hi, Matthew. As a non-practitioner and looking from the outside, one of the things that strikes me is that practitioners are practitioners. They're all about doing, and a lot of this is raising awareness that a service exists and establishing those referral pathways. And I don't think we give enough time in when we're setting up a service to think about that and actually the resource that's required for it. And I've seen it with the memory technology resource rooms, how so much time is going into, and some of those services are, some of the MTRs are relatively new. So much time is required to let people know that the service exists and for people to understand what the service does. And I don't think there's a full consideration of that in terms of the resource requirement. And it is establishing those referral pathways. And we saw it with the PDS grant scheme as well, how so much concerted time was just spent letting people know there was cognitive rehab available and letting people know what that meant, what it means and who's the audience for it as well. So I think certainly for me, from the outside looking in, that's one thing anyway.
Okay.
Yeah, and I mean, sorry, yeah, I think it's about, you know, where you locate those hubs. I mean, those information hubs, and I think that's kind of, you know, is where is the resource that people, and that's why it's been so useful for us to have that partnership with, you know, with the Alzheimer's Society, because actually that is a very identifiable, if you like, brand for people who are supporting care. So when people are thinking of looking for where they access information, then that's an important repository. I think it's how you bring that down to you distill it down to the local level, to the local community level, and how we're able to do it at that level. And I think that's why the post-diagnostic pathway has to start in around that disclosure center. That information, that first kind of signposter has to be there. And I think people need to know, and they need to have ways back into that person or onto the next signposter. So be it, you know, through the dementia advisor. So I think it is about starting there. People don't necessarily always want to, I mean, and you know, we all know here is depending on where people are at and their state of mind when they receive a diagnosis and where their supporters are when they receive a diagnosis, they may or may not want to participate in this. So actually there isn't really any means of cajoling or, you know, forcing people into it. People get to these things in their own time. And I think it is about how you create that soft interface that when people have come to terms with, now I would like to engage with this, is that they're able to do it. It's a very difficult thing to manufacture. And I think that's what we're all finding is challenging. So I think having as much linkage between those partners who are there to deliver it at a local level is that key piece. You know, I think the Alzheimer's Society has certainly been that repository on a lot of occasions for us.
Yeah.
Just to mention, Matthew, there's just two comments there from the audience there. So one person mentioned transport, so something very practical, just transport, and somebody else said give information to the GP. So two good points there.
Yeah, and I think that feedback of information back to the GPs is very important. I think also the encouragement for the GPs to actually read that information when it comes as well. So there's a bit of give and take there, I suppose.
Sorry, just to mention one other comment coming in. Public health nurses are providing multiple service contacts continually to all elderly as they are needed and are well placed to do so. So there's another comment coming through there.
Yeah. And can I? Sorry. Yeah.
Oh, sorry, I was just going to say, yeah, we work with a lot of public health nurses. I would really echo that as well. They're extremely important to us on the ground, not only our dementia advisor service, but actually all of our services. And we would work to link with them very strongly. And often, you know, there's a cross sharing of information there, because we can give a certain amount of expertise in some areas, but we actually need their input and vice versa. But I would also just bring the conversation back to awareness and that local piece. When we developed our mobile information service, which is our blue bus that goes around, you know, we got it into places like farmers markets, Saturday markets, the ploughing championships, anything like that. And what we found is actually that can just start a conversation. And actually, once you start the conversation, you can bring people along, but sometimes you've got to go to where they're at, what they're doing in their community. And for them to see, oh, look, there's something about Alzheimer's or dementia here, and that's in my space. And suddenly they're allowed to connect. And that's, I think, a huge piece in terms of how we bring people into accessing supports and services in a timely way. So I think the more that we can do of that, the better.
Yeah, I think something just to add here too, that is the role of the community. So important, and all of the work that Understand Together have been doing to mobilize the community, and certainly with the cafes, the I mean, the model is plugging into the community and plugging into primary care, so bringing those together. But I do think stigma around dementia is still huge. Unfortunately, a lot of work has been done. But I think in terms of access to services, it's kind of a multi-pronged approach, maybe. Like I know with the Alzheimer Cafe Donnybrook, to come back to that, Matthew, a lot of people who lived like within a quarter of a mile had never heard of it. So I suppose that's one of the really good things, working with Eamon and Anya over in Galway. One of the really great things about having a network and having research and then building a network together is that really you can build more awareness and understanding, but the community is central to that.
Absolutely. I thought it was, you know, it's kind of ironic in this, you know, in this age of the pandemic, you know, that you know, the online, you know, the virtual Dementia Cafe is so vibrant. It's fantastic, you know. It's been a real eye opener for me. I've been hugely impressed by it, you know, by the virtual Dementia Cafes. It's been fantastic.
Cafes, plural. There are now lots of them. Lots of cafe groups. Seriously, lots of cafe groups are going virtual.
Oh, no, I did say cafes. Sorry, it's maybe the audio.
Just another comment coming in there, Matthew. Opening day centres safely is crucial for our members living with dementia. The feedback from our Yarn Social Club members and their family carers is that the disease has progressed in the absence of interaction, connection and participation.
Yeah, yeah, no problem. I just want to very quickly, and I know you're right up against the time. I just very quickly, because we haven't mentioned it, and I see one from Joan Fitzpatrick there. There's still a definite problem for post-diagnostic supports and indeed disclosure for people under the age of 65 with a dementia. I just wonder if MB from the panel wants to have a quick comment on that, because I think it would be a shame to ignore that.
Yeah, I mean, so I suppose within our memory service, we see people who over and under the age of 65, and there's no doubt there is, there's a different approach, and there's some different supports that are necessary. By the same token, I think the things that should be constant are the culture and philosophy, with regards how you try and deliver those supports. I think the settings can be different, and there should be a reflection on people's wishes, regardless of whether you're over 65 and you'd rather maybe be with older people, or whether you're younger and you'd rather be with younger people who are coming to terms with the diagnosis. But I think there's no question that there needs to be special attention. There's very little resource, and I think the other service, from the point of view of what the Department of Health have invested in, is the integrated care program for older persons. Is a phenomenal resource for people over the age of 65, whereby and that's the main means by which I'm able to do the domiciliary visits and have the support system about seeing people with behavioural and psychological symptoms of distress in their own homes. We don't have the same supports for people under the age of 65, and I think it is about so you have sometimes the people with the skill set to maybe address some of those issues in younger people, but without actually the same resource to do it. And I think it's meant, ideally you would like that we would view dementia such as something like cancer, and you would have a resource to deal with the issue, and age would not be the factor. But where dementia and trying to identify resources from dementia are concerned, is we have never adequately resourced younger people with dementia. It is accessing long-term care is such a challenge, accessing suitable settings for long-term care is such a challenge, and then accessing the right information, holistic support around occupational issues and other care issues is always such a challenge for younger people living with dementia would be the experience.
Yeah. And anybody else on the panel? We've probably got time for one more comment.
I mean, just to add, I mean, what was in my mind was timeliness, and if we want to have uptake, that people maybe get that timely diagnosis, so that that they haven't deteriorated or their dementia hasn't progressed. Actually, the earlier you can reach people, and I suppose that would equally apply then to people who are under 65, getting the diagnosis at the right time. So again, it's back to the philosophy of sláinte care around, intervening at the right time and in the right place. So yeah,
you're quite right. Time is always a problem. think we're up against time now, so I'd like to thank the panel: Samantha Taylor, Sean Kennelly, Susan Scally, Dr. Emer Begley. Have I missed anybody? I'm not sure. Have I missed anybody? Don't think so. So listen, thanks so much for your time. I'll hand you back to Carol.
Okay, thanks very much, Matthew. Thanks for moderating today's panel, and thanks to all our panelists and speakers today. Thanks also to Grace, who's been pulling the strings in the background and has made sure everything's run smoothly. And thanks to Engaging Dementia for inviting us to do this wrap-up event. And so in terms of, there'll be a recording available of this forum, and we'll also be producing a report of proceedings that'll be available afterwards as well. And sorry we didn't get around to answering all your questions. I know some interesting comments were coming through there, but we can capture them anyway through the Zoom forum. So thanks for all your comments and questions.
Carol,
and thanks for tuning in today.
One sec, I forgot to thank Carly Duggan. Sorry, Carly.
Okay.
Apologies. You'll get back for that.
Get in there. Okay, so take care, everybody. Have a good rest of the day. Bye now.